out here. Okay. Well, today, if I can get through my headache, we'll end up talking about a little emergencies in children. A refresher for a lot of things, and maybe a little bit new information. This is the new, well, not new, it's been out for quite a while, the Pediatric Assessment Triangle, to get a general impression of the pediatric patient. In other words, sick, not sick. Simple. So, appearance, the work of breathing, and circulation to the skin. Looking at the kid, walk in, and you say, this kid's sick, this kid's not sick. So, appearance. That's your mental status, muscle tone. Now, I don't care if you, pediatricians are, come up with mnemonics just like everybody else, and so they have this cute little, the tickles mnemonic. Tone, the interactiveness, which is part of the mental status exam of a child, of an infant. Consolability. There was a inconsolable child on the airplane last night, but I don't think he was sick. But he was not consolable.
Sorry. Doesn't mean he didn't need to be medicated.
That's for sure. Look or gaze. In other words, is a child looking at, or they not there? The light's on, but they're not home. Speech or cry. So, an older child can speak. Do they have normal speak for the age? Are they speaking? Is their cry abnormal? You know what an abnormal cry sounds like. Obviously, gross abnormalities require immediate intervention. So if they're not, if they're totally floppy, not breathing, difficulty, stridorous, you need to deal with them right, that's a quick answer. So, work of breathing. What's their respiratory rate? What's their respiratory effort? Are they having to sit in a tripod-like position to try to improve their ventilation? Do they have abnormal airway sounds, stridor, obvious rowels, abnormal posturing, retractions, particularly in younger children, nasal flaring? All those things indicate increased work of breathing. Then the circulation. What does their skin look like? What's the color? Are they having normal capillary refill? You should check the capillary refill on any child who looks sick. Do they have pallor? Is there mottling of the skin? Mottling is normal or usual in the immediate newborn period because their skin, the nervous system of their skin is just not established well yet. But mottling is not normal for children out of the neonatal period. Are they cyanotic? Obviously, cyanosis is low circulation, low oxygen level to those fingers, toes, lips, etc. So, whether you stay and play or you go depends on the severity of your assessment of that child at that point. So you have to assess if they require urgent care, assess ABCs, treat immediate life threats, and transport, just like a trauma patient. If the condition is stable, finish your assessment. So, respiratory emergencies are the primary thing we have, the primary thing we deal with in children. In your patient assessment portion, you establish respiratory distress, if they have increased work of breathing, which they're trying to compensate for their respiratory issues. So increased work of breathing may result in adequate gas exchange. If not, they've moved into the serious category, the urgent category. Respiratory failure is inability to compensate for hypoxia. And inability to compensate gets more hypoxic and CO2 retention. And then respiratory arrest is obvious. The patient's not breathing spontaneously. So, your respiratory emergencies start out with foreign body obstruction. And that's biggest chance at infants and toddlers, although I think it was the last lecture I talked about a child who was a 4 to 5 year old who ended up ending up inhaling a piece of a sausage and presented exactly like we're going to talk about these kids, but also had very red face, appeared to be possibly allergic. The sausage wasn't immediately obvious, and the child was treated as an anaphylactic type reaction, and actually did reasonably well and did much better after Marty removed the sausage from the airway. Mild obstruction, mild foreign body obstruction, child's awake, often will have stridor and be drooling. Now you say, well, how can I determine that from, let's say, epiglottitis, where they're awake, they have stridor, and they're drooling? Well, they're drooling for a different reason. They can't swallow. In this case, they can't swallow very well, but one is sick, they has a high fever, they're ill, and they've been ill for a while. It's not an immediate thing. This is an immediate thing. Increased work of breathing. So they may have retractions if they're small, if they're young enough, but they generally have pretty good color. If it's mild severe obstruction, they're now cyanotic, unconscious, low O2 sat. Okay. You practice. Foreign body removing in responsive infants, awake, back slaps, chest thrusts. Foreign body from an unresponsive infant, look, remove the object if you can. If not, CPR, chest compressions. Foreign body in children, abdominal thrust, modified Heimlich. The child becomes unresponsive, supine, chest compressions, open the airway, look with the laryngoscope. If you have a foreign body, sausage, remove it. Croup. Well, anybody seen croup the last couple weeks? Yes, it's out there and it's happening, and this is the time of year. And the springtime. It's a bimodal thing, fall, early fall particularly, and then springtime, the biggest times around here. Now, it may be a viral infection of the upper airway, probably is, and the parent will generally give you a story that the child has been slightly ill with a cold for a couple days. The onset is typically abrupt. Child goes to bed and wakes up. Grouping. Typically, you'll see an alert child or toddler with audible stridor. Gets worse when he's agitated. So when you first show up, if the child is really scared, and he'll be agitated and really croupy. Croup is a barky cough. Everybody's probably heard it. If you have children, your kids have probably had it. some increased work of breathing, normal skin color generally. Now, some kids get it really bad, and the typical story is that the child had a mild case the night before, and it seemed okay during the day. Now back in bed, there's got to be something evil in the bedroom, the monster in the closet kind of thing. The kid wakes up and is really severe the second night or the third night. Severe croup, stridor at rest, they just sitting there without being agitated, and they don't want to be agitated then. Barky cough, marked retraction, very distressed. And it can go on worse to impending respiratory failure, depressed LOC, stridor at rest, severe retraction, poor air entry, cyanosis, pallor. So it can get bad. Management. Okay. We try not to agitate the kid further. So typically you let the mom or the dad, whoever the kid relates to the best, sit with the child or sit with them on their lap, and mild croup, just nebulized normal saline. We'll usually take it. Now, the old trick, we used to tell the mom or dad, whoever called, go in the bathroom, turn the shower on full hot, close the door, let it steam up. Then you take the kid into the steamy room. That's what you can do at home with your own kids. Saves the trip. Now for severe croup, severe retractions, cyanosis, anxious, very anxious kid, or impending respiratory failure, O2 high flow, humidified, but we're going to give them racemic epinephrine, and all severe kids with croup should get a steroid. Now, the problem with giving a steroid for you is that implies, because the only way we're going to give steroids is either by IM or IV, and preferably IV. The problem is, then you're going to agitate the kid tremendously starting an IV. So the steroid, somewhere in this treatment, the child's going to have to start it. Now, if we could put Decadron on board. There is an oral Decadron. It tastes terrible, so the kids won't take it anyway. So you threaten them, say, you get a shot or you get the oral Decadron. We can possibly, and it does come in pill form, but little kids don't take pills. So, what about racemic epinephrine? Now, United States and Canada is the only place I know that has racemic epinephrine. Racemic epinephrine cannot be, they don't make it for use in other countries, to my knowledge. Maybe England. Racemic epinephrine is a mixture. Epinephrine comes as two isomeric forms. An isomer means like a copycat, only one is turned to the right and one is turned to the left, the molecule. So it's the D, dextrose, or the L, levo forms, so right and left forms, and the racemic is a mixture of both forms. And it comes as a 2.25% solution. So it's more concentrated than regular epinephrine. And why did we come up with it? Well, because we thought that the racemic mixture would decrease tachycardia and hypertension when given. Well, it turns out studies showed no difference. which is probably one of the reasons why epinephrine or racemic is not available any place except places where we're willing to spend a lot of money for the product. Because racemic is much more expensive than standard run-of-the-mill epinephrine. Well, because we have it and we use it, and it is the sort of the gold standard in this country for racemic epinephrine. If you notice this thing, it says use it as 0.05 mils per kilogram with a max of 0.5 mils. Then down below, they would give you the recommended amounts. So if you figure that out, you're only talking about a 10-kilo child would be up to the 0.5 already. So down here it says 20 to 40 kilos use 0.5 cc's and 5 cc's of normal saline by med-neb and mask, and a mask. You generally don't put the mask on the kid because that really agitates them, so you just blow it by. If the child's less than 20 kilos, use 1/4 of a cc. That's easier to remember. Now, what if you didn't have, if you ran out of racemic, or it wasn't restocked, or just like every other drug that we're having nowadays, including normal saline and D5, the drug company may run out of it. Now, they blame it on the hurricane, but we were having that problem before the hurricane too. I can't imagine every drug in the world is made in Texas or and certainly they're probably not made in the Dominican Republic or someplace. So epinephrine, regular epinephrine, is the L isomer only. So you can use regular epinephrine, and the dose of regular epinephrine is 0.5 mil per kilo with a max of 5 mils of 1 to 1,000 put in saline and nebulized. Pretty easy. But for right now, we're not going to run out of racemic epinephrine. I've been assured we have enough around. Now, Solumedrol is 2 milligrams per kilo, IV, IO, or IM. Very seldom would you ever have the need to agitate the kid. I prefer it IV, so don't start the IV. Let the ED do it. Now, classically, we've told you, if you use racemic epinephrine, tell the emergency department. Because most of the time when you use racemic, you get in there and the kid looks really good. They're not crouping, they're not doing anything, and nowadays you can't get out of the emergency department in 2 hours generally, but in the old days you could, and sometimes they would not check the kid out very well and not sit and watch them and send them, and then there can be a rebound. And the rebound, they start crouping just as bad, and you have to treat them again. It's also, if you use racemic, you'll have to tell them that you did or didn't give any steroids. Kids should get a dose of Decadron there. When they get there, they can take it orally then, if they're not agitated. We have a case in our case reviews of croup that we managed with it. So the max dose for a child is probably for you is about 60 milligrams, which is 2 milligrams per kilo. You're getting up to a 30 kilogram kid then. Okay, epiglottitis. Inflammation of the supraglottic structures, classic presentation, sick, sick, sick. They've been sick. Now they're anxious and they look sick. They have a fever. Anxious, sitting in sniffing position, drooling because The problem is it hurts to swallow. They can't swallow. If they can talk, they can't talk very well. In fact, I reviewed a case of a adult with epiglottitis, and the person kept handing notes to the ED physician saying that they couldn't talk because their throat hurt so bad. And there was drool on the notes, so you got the idea they couldn't handle the saliva. Increased work of breathing, pallor, cyanosis. Very rare in immunized children now. I haven't read of a case in our, I haven't read a case in 15 years in our transports or even in the ED. Have you seen a kid? I haven't seen. Now we've seen a couple of adults with epiglottitis, and in older persons, epiglottitis was basically caused by the bacteria Haemophilus influenza, H flu. That's the one we immunized the kids to stop meningitis, basically, but it has the salutary effect of also taking out the H flu that was giving them rarely or unusually giving them epiglottitis. But you can, the cases that I've seen recently have been in adults, maybe H flu, Haemophilus influenza, but also staph. Some versions of staph can cause it. Interesting sidebar, which is only probably interesting to me, is that that I picked up at the Heart Association Resuscitation Conference this week from the research. When we test medications in animals, we make some judgments that they really are effective. If they work in rats, they work in people. That doesn't always work. And one of the problems with testing antibiotics is that when you can't kill a rat with Staph aureus. Rats have this ability to fend off you. In fact, it says you have to drown them in Staph aureus in order to kill a rat, because they won't catch it, and then so you can't use it to test them if the drug works. It always works because they don't get Staph aureus. Okay, what do you do with epiglottitis? If you have an epiglottitis, it'll probably be more of an adult, be a little easier to work with, but if you had suspect an epiglottitis in children, try to calm the patient. Sitting position is preferable. Sitting as the parent, if it's a child. Don't attempt to visualize the pharynx. There'll be drooling, stridorous. Nebulized normal saline helps, just like it does for croup. But for cyanosis and severe stridor, try the racemic epinephrine. Even in an adult, it may give you some improvement. Okay? Don't attempt intubation at that point. However, if they have respiratory arrest or cyanosis, lay them down, positive pressure ventilation with appropriate neck position, head position. If you can't ventilate, assess for intubation. What do you got to lose at that point? The patient is unconscious. If you're unsuccessful in ventilating, you could consider temporizing with a needle crike in a child. In an adult, that would be not worthless, so just do a crike. I'm willing to bet that nobody in the room will see a child in this. The odds are very good that we will never see a child with epiglottitis nowadays. Until the zombie apocalypse. No, so we'll do something we see all the time. Asthma. Your three main components of asthma are bronchospasm, inflammation, and increased mucus production. So I got a little pointer here. Oh yeah, it works. So with normal bronchial tubes and bronchus and alveoli on this side, during the asthma attack, you get narrowing of the bronchi, the alveoli fill with trapped air, because the big problem is can't get air out. And also when you get enough trapped air in there, you begin to start worrying a little bit about auto PEEP. And if you start putting more air in that can't come out, then you definitely have auto PEEP, and that's where people's, their pressures drop. Excessive mucus in the bronchi, you get inflammatory changes with swelling, and then in more mucus, so you end up with mucus plugs and bronchial constriction. What triggers your asthma attack? Well, first of all, you have to have asthma, at least the probably genetic propensity toward asthma, and allergens can trigger it. Soot, smoke, secondhand smoke, cold air. Many of us have exercise-induced asthma, respiratory infection, emotional stress. Management, asthma is pretty straightforward. Literally continuous med-nebs with albuterol and Atrovent. I think everyone who you are getting a 911 call for asthma who you are starting to treat, give them Solumedrol, dose 2 milligram per kilo. I would prefer that IV. I'd like you to have an IV in them anyway. If they have severe asthma, they're not responding to your med-neb, or they're responding slowly, start them on an epi-drip. Start out at 0.1 mic per kilo per minute and titrate. Last thing in the thing, the last thing, not the first thing, the last thing is if they're not responding to that epi-drip or responding slowly, if they're in status asthmaticus, which means you cannot break that attack, magnesium 25 to 50 milligram per kilo over 10 minutes. Now, can you use CPAP? Yes and no. You can use CPAP along with the, if you can use CPAP with the med-neb, you could try it. The problem is CPAP increases the PEEP, the whole point, increases the airway pressure throughout thing, and it may get more oxygen in, but it may also make it worse if they get more air trapping and you get auto PEEP and you drop the person's pressure. So that's why we have paramedics who can think about that sort of thing. That's why we don't let most of the time we don't let EMTs do CPAP except under certain conditions. CPAP for congestive failure is a whole lot different than CPAP for asthma. Okay, back to kids though. Bronchiolitis. Most commonly caused by RSV. Very contagious for children. I don't think I've ever seen an adult caregiver get RSV. Probably happens, but I don't, you know, it's for them it'd be a cold. So this is very contagious, probably respiratory syncytial virus, RSV. Uncommonly, it's caused by mycoplasma, which is a strange bacteria. Typically it occurs in winter. We are starting into the RSV season. Typically younger kids, so those under 2 years of age. Characteristics are mild to moderate retractions, tachypnea, maybe a low-grade fever, diffuse wheezing and crackles. My experience is mostly you start hearing expiratory crackles before you hear inspiratory crackles, but that's a hard thing to determine. Just you will hear rowels. And you say, well, this kid's got congestive heart failure. No, children don't, most children don't get congestive heart failure. The odds are it's going to be, you know, bronchiolitis. Mild hypoxia. You say, well, okay, that's a kid with a cold, a sick kid. But severe bronchiolitis is any of those below. So, any of these, persistent increased respiratory effort, tachypnea, nasal flaring, retractions, accessory muscle, and grunting. Little kids are grunting when they're breathing. That means they're really working. Or an SpO2 less than 95%. These kids are really breathing a lot, so they should have a good SpO2. Well, apnea is kind of a no-brainer, isn't it? You know, if they've been working so hard that they're now apneic. So, acute respiratory failure. So, that's severe bronchiolitis, anything like this. So, persistent increased respiratory effort. So, now, who is likely to have respiratory failure? If you look at the kid who is obtunded or excessively sleepy, you know, they should be alert and anxious if they're having trouble breathing. Severe retractions. I mean, when you see them taking breaths and everything sinks in around their little chest, their little ribs. Diminished breath sounds, just like asthma. No noise is bad. Moderate to severe hypoxia. And the kids who are most at risk are in the first few months of life, children who were premature, and now it's in the first few months of their life, lung disease, congenital lung disease, congenital heart disease, and kids with immunodeficiency. Now, pre-hospital, your care is just like for asthma. Oxygen, try to get their O2 sats above 92. Position of comfort. Use that. One of the characteristics of the kids is it's like they start out like a cold, so they have a lot of snot in their nose. So we use bulb suction to clear their nose. Kids breathe better when they're, you know, we're obligate nose breathers. That's how you can nurse, is you suck, but you can breathe through your nose. It's characteristic of human beings and all mammals. Bulb suctioning is, so you say, where's my bulb suction? Your bulb suction is in your OB kit. Get your bulb suction out, get the kid's nose clean, he'll breathe better. You can try, albuterol is universally a failure, but we've got wheezes, and we've got crap, and it doesn't hurt to try the albuterol. If you've got any wheezes, by all means use albuterol. Wheezes need wheeze medicine. Assess their fluid status. They may be dehydrated. They often are, because they've been breathing hard, and you blow off a lot. You lose a lot of water by breathing. That's why we use humidified air to replace some of this. Okay, now we'll go on to really sick. Pneumonia. Pneumonia is hard to diagnose in newborns because they generally don't run a fever. And they can't tell you much, and they don't cough usually. So newborns have, if they have pneumonia, they'll often have poor feeding, irritability, then obviously tachypnea, retractions, grunting, and or hypoxemia. But they don't declare their pneumonia quite as easily as the rest of us, because in infants, they'll cough. Adults cough. Usually it's we have a history of upper respiratory infection in infants, followed by tachypnea, retractions, hypoxemia. Then the cough is persistent, congestion, fever, irritability, decreased feeding also, and some go to sepsis, particularly with pneumococcus. Children and adolescents have the same thing: fever, cough, congestion, chest pain, dehydration, lethargy, maybe sepsis. How do you treat pneumonia? Well, right now we don't carry antibiotics, so position of comfort, patent airway, O2 to keep their SpO2 above 90, manage respirations. If they wheeze, treat them with wheeze medicine. Fluids, especially if they're below the norm for their age, for their blood pressure, or they're extremely tachycardic. Pertussis, which we are now seeing on a regular basis because the Darwinian principles haven't taken over entirely, and so we still have people who are not immunizing their kids, and their kids haven't got the rest of us yet. So pertussis, extremely contagious, spread through respiratory droplets. Starts out symptoms just like a common cold, then significant bouts of coughing, and severe enough spasmodic coughing that during the coughing habit you can't stop coughing, and leads to you'll get often undersaturation, so cyanosis, hypoxia, and very young children can die from pertussis. Adults just sit and cough forever. We've had a couple of nurses who've gotten pertussis through exposure at triage, and they stay sick until you treat them with antibiotic. And it's treatable with antibiotics, but treatment is supportive. Pre-hospital treatment is supportive. Maintain oxygenation, manage airway, and use personal protection. And of course, most of you have been immunized, so you're probably not at risk. Although we do still have the P in DPT. So you need a booster. Okay, septic shock in children. So, clinical definition, we've been changing the rules around what's the definition of sepsis. I think we're still talking with you about what is the current thought. So, suspected infection manifested by either hypothermia or hyperthermia, so either a fever or sub-normal temperature, along with clinical signs of inadequate tissue perfusion, altered mental status, decreased capillary refill, mottled cool extremities, decreased urine output. Hopefully you're not with the person long enough to know that they have decreased urine output, but you ask the mom, how many diapers have you changed today? If she says none, that's not normal, unless it's first thing in the morning. But she should have changed the diaper overnight. Hypotension, which, you know, so hypotension requires that you do attempt to get a blood pressure on the child. I see an awful lot of kids transported with heart rate, pulse, blood pressure not attempted. No, why? Septic shock. So, suspected infection with those things. Treat. How do you treat it? Maintain oxygenation. 2 mils per kilo fluid bolus. You're looking to maintain to get to age-appropriate blood pressure, which means you have to take the blood pressure. You can repeat that to a total of, I'll let you do it, 3 boluses altogether. Now, hopefully, except maybe for North Country, hopefully most of you won't be in a position where you will be with someone who is septic that long. If the patient is still hypotensive, we're going to use norepinephrine. Norepinephrine is the drug of choice, the pressor of choice for septic shock and for cardiogenic shock. Norepinephrine infusion, you titrate to age-appropriate blood pressure. Now, but that's after some fluids. And it may be concurrent if they're extremely shocky. Now, the problem with norepinephrine, I'll just warn you, you'd want to call, if you're treating an adult or a child with norepinephrine, their blood pressure may be rising, but their heart rate may start falling, which might be counteractive. It may, so you call to medical control and say, this is what's going on. Our pressure is our heart rate is coming down. Can I add an epinephrine drip to that? You put both things on. We push the epinephrine because epinephrine is more chronotropic. It'll jump up your heart rate. And obviously notify the receiving facility that this is a septic shock alert. Cardiogenic shock. Fairly uncommon in children, except for, so it's pump failure due to either congenital defect or an extreme rhythm disturbance, and supraventricular tachycardia is the most common, and paroxysmal atrial flutter or fib is fairly common. So it's usually an SVT though. Myocarditis, other infection can cause cardiogenic shock. Near drowning, stuff like that can give you cardiogenic shock. So symptoms of cardiogenic shock, not to include near drowning, are listless and lethargic, increased work of breathing, impaired circulation, mottled cyanotic skin, sweating with feet. Now, I've seen a couple of kids in my career where the mom says, you know, I can't figure it out. He doesn't seem to have a fever, but every time I try to feed him, he sweats. And so how long has this been going on? Oh, 2-3 days. And I said, did you notice his heart's beating like this? Who said that? You know, he does that all the time, off and on. He had a PSVT. How would you treat a standard PSVT in an infant who was not needing to be sparked? You could cardiovert him, but most of the time you can treat him with adenosine if it's a pure narrow complex SVT. If it's a wide complex SVT, don't want you to use adenosine and stuff. If you need to treat him, with a drug. We'd probably go with amiodarone, or transport them and we'll take care of them. Let Marty worry about it. Okay, well, let's talk about the heart diseases. We get two flavors of heart disease. Cyanotic heart disease, in other words, they are cyanotic at rest, which means they're mixing unoxygenated blood with oxygenated blood, and so the problem is something at the level of the heart is mixing the blood. So the usual things are things like tricuspid atresia, ablation, partial narrowing or significant narrowing of the tricuspid valve, transposition of the great vessels where the pulmonary and aortic are just reversed. So the pulmonary artery essentially comes out of the left heart instead of out of the right heart. Kind of a bad deal there. Tetralogy of Fallot, which means that everything is messed up. And there's right to left shunts, and there's transposition of the great vessels, and so the net effect is for a greater amount or a lesser amount, you mix oxygenated blood from the pulmonary system with unoxygenated blood, and you end up getting varying degrees of cyanosis. And of course, it's worse when the kid is agitated. So if mom tells you every time he gets mad he turns blue, that may not be a good sign. Non-cyanotic heart disease or atrial septal defects, because ultimately the blood does get circulated through the pulmonary system, and so you have adequate blood through the left heart. Ventricular septal defects, same thing. If they're really big, it's a right to left shunt. If it's not so big, or a left to right shunt. If it's not so big, it's it's not shunting as much, but ultimately all the blood gets oxygenated. And then the patent ductus arteriosus, that's the ductus is the bypass of the lung during when you're in utero. You don't need to oxygenate, you don't need to circulate blood through the lung because it's not going to oxygenate it. So it bypasses, goes directly from the right side, bypasses the lung, goes to the aorta. That's normally shut off when you start breathing. Your first breath starts this closing down. It spasms, closes down, and then ultimately drops off. Some people keep this open. some things, but that's why we don't like to use, we don't like to give moms ibuprofens and things near delivery, because ibuprofen's been known to keep the ductus open. So, what are you going to do if you take care of a child that you suspect has a cardiovascular emergency? Now, if they have paroxysmal atrial tachycardia, or if they have anything, so you can do your assessment, looking at the patient assessment triangle. Do they look sick? Well, if they look really sick, they're having trouble breathing, that means you need immediate temporizing care and diesel. Need rapid transport. So think about the underlying cause, the priority of treatment. Supportive is obviously oxygenation. Can all use oxygen. If they have an underlying rhythm disturbance like PSVT, narrow complex, treat it. I don't think I'm trying to think, I've been able to treat any of the kids I've seen with PSVT, even infants. I haven't had to spark one yet, but that isn't out of the question. If you had a child who was in cardiogenic shock with a PSVT, that's a patient that you would go ahead and sedate if necessary and spark. Using about 2 joules per kilo. You go up to 4. After your intervention, obviously you reassess your ABCs. All right. Should we take a break for a little bit? We got a question, Rod.
Well, it's the 2 to 4 joules per kilo is, there was some comments back here about that being a defibrillation dose, but as you probably experienced at the conference, that energy doses, they're starting to hit a little higher, so if you wanted to take a minute and try to
Well, just that, yeah, in actual fact, you could probably, the defibrillation doses for children we'll stick with that, but we have gone with higher doses on children. It seems to work better. My inclination has never been to go to the low dose that's been recommended for adults. I mean, why go to 50 to try to convert AFib when I know that 100 almost always does. So hundreds are kind of nice for adults. 2 to 4 for kids. It is almost a defibrillating dose, but you still have to. We've not found any harm with using up to 9 joules per kilo on kids. How did they figure that out? Well, they sort of forgot about it, or they put an adult pad on the kid, or they couldn't dial it down, so they used a bigger dose, and it doesn't seem to make any difference. So don't go to tiny doses on kids. Don't have to think about new numbers. Okay. Let's take a break for about 10. Okay, I need to clear one thing up that I did not make, that I apparently was confusing about. When I was talking about Solumedrol, using Solumedrol for the croup, I really only want you to give it IV. I do not want you to give it IM because, and so this, basically I'm trying to tell you that although the kids will get a steroid, they don't have to get it from you. And so if you're going to, I don't want you agitating the kid, and nothing agitates a kid better than trying to stick them with a needle. So if you already have an IV in because the kid was so severely crouped, then go ahead and use the Solumedrol. Otherwise, don't give it IM any more than, don't approach him with a needle. Okay? All right, seizures. Simple seizures. Oh, okay. Febrile seizure, a simple seizure, fever in a child aged 6 months to 5 years, single seizure, generalized, tonic-clonic, usually lasts less than 15 minutes. It's by definition. Now, I have to tell you that most people get very excited if their kids are seizing for 14 minutes, or they should. But the pediatricians think, that's a simple seizure. No underlying neurologic abnormality by exam or by developmental history. Fever is not, now, the fever cannot be, to be a simple seizure, febrile seizure, the fever can't be caused by meningitis. That's not a simple seizure. Can't be caused by encephalitis, which is viral meningitis, for lack of better words, or any other illness affecting the brain. Seizure has to be generalized clonic or tonic-clonic. Treatment focus for a simple seizure is oxygenation and management of the fever. So we try to lower the fever. So don't expose the kid enough for cooling and but not for shivering, and acetaminophen, usually suppository. Remember, take the tinfoil off. Complex seizures. Age, neurologic status before the illness, and fever are the same as for the simple fever. In other words, it's not a complex seizure. If they have a seizure due to meningitis, that's meningitis. That's a complication of meningitis. So a complex seizure is either going to be focal or prolonged, more than 15 minutes, or multiple seizures occurring in close succession. Simple definition is they never wake up, they never really have a true post-ictal phase, and they go right into another seizure. That's complex seizure, otherwise known as status. Or a complex seizure that goes more than, by definition, more than 15 minutes. We have a case that we'll talk about. Management, oxygenation, reduction of fever, and treatment with midazolam. What's your dose of midazolam? Per kilo. Yeah. The actual dose is very complicated. It turns out to be 25 to 50, or 50 to 100 micrograms per, which is 0.1. 0.1. Okay.
Dr. Woodward?
Yes.
Can we give that midazolam nasally to peds rather than say IM?
Actually, it's a good question because nasally is one of the approved ways of treating a child with. That assumes, now, Okay. Could you give it, well, we give fentanyl nasally if you know, with a simple, let's say a kid broke his wrist and you, for some reason, you don't have enough desire to start an IV in this kid, you could use nasal fentanyl. You can use, nasal midazolam has been used. The problem with it, it's apparently quite irritating to the nose and the throat. So it causes, so when they wake up, that may be a little bit of a problem. So it works IM. I much prefer you to have an IV in a kid who's in status, because you're probably going to have to use another dose.
Yes.
And so it's kind of it's kind of volume related also, you know, how many times can you stick stuff. So if you're in a pinch, if you're in a bad place and the kid is seizing and you couldn't get a line in them,
Or maybe just for that initial dose.
or for the initial dose while you try to get a line in him, could you do that instead of doing IM? Well, the other thing to think about is my experience with kids with having seizures is often they're pretty snotty. And it doesn't absorb as well. I don't want you to give it rectally, so it's a choice.
So 3 years ago, we had done some research on whether or not to give it IM because it seemed to make sense. All the research that we looked at showed that there is no difference in onset of action or termination or cessation of seizure. The one thing, as Dr. Roberts is alluding to right now, especially with young kids, is they always have snot in their nose, which, and the other issue was the negative side effects of giving it nasally were obviously they're much more than giving it. So because there's increased side effects of intranasal and there's no greater onset of action, that doesn't make sense.
No. So we by sort of by rule out, I prefer it to go IM rather than IN, as probably a little bit more. Most of the studies they did on nasal, on intranasal for seizures, or intranasal Versed was in awake in kids who they were using it for sedation rather than for. So most of it has been tested in an awake kid, not a kid who was actively seizing. I mean, you're not going to treat the kid unless it's a complex, prolonged seizure. And my guess is they're pretty snotty at that point. I don't want you to start an IO on a kid just to get a line in, just because he's, you know, that's not good either. But so, you know, if we thought about it and we didn't think it would necessarily be a great idea. Okay, apparent life-threatening event, an ALTI. That's a group of symptoms, not a disease, generally seen in infants under 1 year of age, but can occur up to 2 years of age. Most patients have a normal exam when you get there. So what the hell is this? Well, it's an episode in an infant which is frightening to the observer and includes one or more of the following: apnea, that gets most people excited; color change, they become extremely pale or they become cyanotic; marked change in muscle tone, flaccid, or they have a apparent what appears to be a tonic type of or clonic type of seizure; gagging or choking, it's always exciting. So that is an apparent life-threatening event to the observer. And when you get there, the kid may be perfect, look perfectly okay. but the parent tells you this. So if it's a real infant, we get real excited, like, oh, the kid didn't breathe. Well, is this a kid who's going to go on and have another apneic episode? Is this a pre-SIDS kind of event? That's the kind of thing we're concerned about. So your management is history, support the ABCs, manage airway. Any respiratory distress is automatic. If the kid looks sick when you get there or is having trouble breathing, that's an automatic, isn't it? EKG, at least do a rhythm strip to see if there's any EKG abnormalities. If they have a PSVT, well, then you got something to deal with. Consider a blood glucose, always good, especially if you're going to start an IV. Now, a detailed description of the event. All these patients should be transported for further evaluation. If the caregiver says, no, they look okay to me now, I'm going to keep them, try to talk them into that. If they're still adamant, talk to medical control and put them on the phone with medical control. Online medical contact is mandatory for anyone who wants to refuse if it's an ALTI. Simple thing, tell them, hey, if you were worried enough to call us, we're worried enough about this too. SIDS. A lot of discussion about this at the resus thing because, basically, out-of-hospital cardiac arrest occurs in pediatrics occurs in three distinct groups. The older kids, the teenagers, because pediatricians claim you until you're up to 18. And let me tell you, a lot of 14-year-olds look like they're way over 18. Judge Ray Moore had that problem, I guess. Ditching. But so sudden cardiac arrest in a teenager is really almost like an adult cardiac arrest, and we're going to talk about that. SIDS, infant cardiac arrest, SIDS is probably respiratory. We don't really know. It may be. It turns out that about less than 25% can be attributed to genetic cardiac things. So that's why you want to have the rhythm strip too. If you on a kid with an ALTI or a kid with a, and then there's the kids in between, the teenagers, or like from about 12 down to 1, that if they have a cardiac arrest, it's respiratory usually. Now that takes out congenital heart disease, which is good. But I mean, most kids will have a respiratory-induced cardiac arrest. Sudden infant death, we don't know for sure what happens to them, but it's sudden, without apparent cause, during sleep. Sometimes we know some of the things that contribute to it, such as there's an association, we don't know that it causes it, but there's an association with a smoker in the house, there's an association with some familiar association, there's an association with how you put the kid down. We don't put kids to sleep. How do you put kids to sleep now in their crib? On their back. So, usually infants less than 6 months of age. It's hard for us to differentiate between SIDS and sometimes child abuse, but that's up for the coroner or the ME. So, interventions, unless there's obvious sign of death, rigor, lividity, etc. You guys know how to do that. Start CPR, Follow protocol for cardiac arrest. We terminate resuscitation after consult with base station or a family physician at the scene, which is almost never. I don't think I've seen a family physician at the scene in 35 years here. Support the parents, avoid questions or comments suggesting blame, observe the position of the child, the location of the child, anything, objects around the child, behavior of all adults present, explanation provided, vomitus in mouth, foreign body present, and report all observations to medical control. Write it up, your observation. Now, an interesting, one of the studies that was reported on, and actually partly came out of Oregon, Washington area, partly out of California, is that it was on the likelihood of a child getting bystander CPR based on neighborhood ethnic composition. And the chances, so whether it's the SIDS, whether it's a child arresting, remember the usual bystanders are the family, because almost all cardiac arrests occur in the home. The chance, if you're in a white neighborhood and a white kid, you've got a 95% chance of having CPR. If you're a black kid in a black neighborhood, you have about a 50% chance of having CPR by bystanders. That's your own family. If you're Hispanic, in a Hispanic neighborhood, you have a 30% chance or less of having. Now, is that just ethnic, sort of a ethnic approach to people who are apparently dead? Is it education? Is it, you know, what? It's just out there. So if you go into a Hispanic family's house and they're not doing CPR, don't think it's because they, you know, had child abused that kid. So that's why we can't, you know, we have to work instead in increasing citizen CPR, bystander CPR on people. Okay, pediatric trauma. Injury mortality surpasses everything else, all childhood illnesses combined, mortality from traumas. And it's your anatomy, physiology, and mechanisms of injury produce distinct patterns of injury. Mechanisms of injury are related to age and stage of development. So younger children have different injury pattern than older children. Neurologic and respiratory derangements far exceed hemodynamic. In other words, trauma shock is more likely to be caused by a neurologic injury or respiratory problem than it is by simply bleeding. So, kids have larger head, smaller jaw. Makes it a little bit more difficult for your intubation tube. Shorter, narrow, funnel-shaped airway. Soft cranium in infants, open fontanelles until sometimes after a year. That allows a lot of swelling inside the head before increased intracranial pressure. More cognitive development to come. Prominent occiput in a little kid, so you have to put a pad under their shoulders in order to get the plane of the face parallel to the spine board, and you need to do often jaw thrust to get that airway open. Cervical spine, very flexible. The ligaments are extremely flexible. There's a little anterior wedging of all, compared to adults, of all the vertebra. They come up as you get older. Flat facet joints, which makes them a lot more mobile and a lot more likely to sublux, to slide off each other. And then it's not a problem for paramedics, but for us, when we look at a kid's cervical spine film, you can be fooled by what's called pseudo-subluxation. It looks like the vertebrae are sliding forward on each other. It's not really true. Now, chest, extremely pliable. Very soft wall, horizontally aligned ribs, weak intercostal muscles. This is why you get retractions when they have respiratory distress. Rib fracture, if they fracture a rib, that indicates incredible force, because usually the rib cage is so pliable that the force is actually transmitted more into the lung itself. So you get lung contusions, you get pneumothorax, etc. Tension pneumothorax in a child is deadly. That's probably, if you have a child who's in shock or in a cardiac arrest after a motor vehicle accident or a significant injury, they probably have a pneumothorax. Abdomen is soft, thin. Liver is big compared to the rest of them, so it rides very low, so it could be injured easier. Bladder's quite high. It can be injured. Multiple injuries are common. So you have to know age-specific vital signs. Don't depend on your memory. Have them when you're at the scene. Have your little cheat sheets handy so you can look at it. All your Broslow tapes will tell you what it should be too. They have a small blood volume, decreased functional residual capacity in the lung. This means that they're more likely to desaturate then. However, they have a vigorous compensatory response to blood loss, particularly. But a limited cardiorespiratory reserve, and so they will suddenly deteriorate. Now, so, normal heart rate, blood pressure. So, blood pressure's here, and you have to have more than 30% blood loss before you start dropping your pressure. So pressure in an injured kid makes you feel a little bit better, but you can't bet on it. But look at what happened. Their compensation is they just crank their heart rate up along with blood pressure, along with loss of blood. The cardiac output, however, as they're losing blood, begins to drop slowly, but because their heart rate is going up so fast, it maintains pretty well even out to 30%, but at 30%, they run out of that reserve and everything falls off. Their blood pressure just drops. Now their heart rate's going to start dropping, and then they're really in trouble. So they've lost they're at this is sort of the magic number at 30% blood loss. So you don't want to get them You want to start managing that before they get there. Don't forget thermal regulation. They've got a lot of body surface area compared to their mass. Thin skin, they don't have much insulation. Prevent hypothermia, particularly infants. Yeah, big differences. Compared to adults, kids have a big tongue. What does that mean? Well, they're more likely with position then of their head and neck to have airway obstruction from their tongue. Remember that in an unconscious person, the tongue is the major culprit. High anterior larynx. That makes it harder to do intubation. It suggests a straight blade. Big occiput, so they need padding under the torso, especially for infants. Head, they're more likely in infants to injure their head over their torso. So they have CNS problems, and then if they do have torso injuries, respiratory problems associated with head injury, then they go to shock from their respiratory problem. Much smaller torso, so they don't get a lot of truncal injuries usually. Much larger head, more brain injuries, body's more compact, so multiple injuries. Their whole body absorbs the blow. Medications and fluids, use your length-based measurements. Don't try to remember it. I don't remember it. Don't you remember it? I always cheat and look at my cheat sheet. That way you never have to say you're sorry when I call you. They have very soft outer shells, so they get underlying organ injuries easily. They lose, don't let them get cold. Child alert, child abuse. Be alert. Suspect child abuse. If the injury, the mechanism the adults tell you that happened with that injury seem to conflict with the actual injury. Suspicious injuries are obviously cigarette burns, bruises of varying ages, belt marks. Don't forget that sometimes when you see bruises of varying ages in kids, the kid may have a hematologic abnormality. But still be suspicious. Child with repeated injuries, if they blame others, he did it, no, she did it. Procrastination by the caretaker in seeking aid for the child. Remember the ethnic differences though too. Sexual abuse may accompany physical abuse. Just remember that too. So, treat injuries per protocol, transport without delay for critical cases, document what the caretaker says, note the environment, the same things you do when you go in the SIDS thing, be a little bit more careful with that if you think that there's child abuse. Clothing stains, can bring clothing in, encourage the caretaker to, if they don't transport the child, then contact medical control. You may have to get authorities there at that point. I think we're still okay simply to tell and to document in your chart that you tell the physician and nurses that this is a potential or probable child abuse case. We have not got to the point where I don't think we have to make, we're mandatory reporters, but we can pass that off, I still believe, to medical at the hospital. Now, it is possible to call and do that yourself. Unfortunately, that probably would I think the child abuse and adult abuse, elder abuse folk would rather have it come through the hospital, but we've not had any major problems with that, so whatever you feel comfortable. Just remember, you are a mandatory reporter under the law. Support, reassure the child, etc. Now, infant-child death scenes, we already talked about that, but just to reiterate, position of the infant when originally found, where they're found, what crib, waterbed, bassinet, etc. Position of the face, was it covered by blankets and bedding? You may not know. I mean, obviously, if you get there and they're doing CPR, you can't. Was the infant or child sleeping alone? Airway obstruction, secretions, any secretions noted on the bedding, treatments rendered, etc. Resuscitation takes precedence, though, over documentation. Now, medical control nowadays will divert certain categories of pediatric trauma to level 1 facilities in Portland because they have pediatric level 1 facilities. But early contact with medical control is mandated to determine that destination. Now, immediate life threats with physiologic or anatomic criteria for immediate trauma triage are uncontrolled airway, hemorrhage, shock, multi-system trauma in shock. I don't want you stuck on the bridge with a kid in this thing. Non-immediate life threats, in other words, modified trauma, a majority of these patients will probably, because, you know, if you have a kid who everything's controlled, you've got an isolated head injury, but you've even got them intubated, the pressure's okay, they may be diverted, because that child's going to be admitted, no matter what, you know that child's going to be admitted to PEDS ICU. So, anytime you're unclear, or if you have an anxiety that, and you never can tell when you're going to have a bridge lift or when there's going to be a, 5 o'clock is really difficult to get any place, either way. And you always are okay to take those kids to Peace Health. You are going to, they're going to be transferred when stable. If you talk to medical control and you're in a good, let me tell you, the trauma surgeons do not want you stuck on the bridge with an injured child either. Special healthcare needs. We've got a little bit of that around here. Tracheostomies. The most common problem with a kid with a tracheostomy, urgent problem, is that the tube gets obstructed with secretions. Assess tube position, suction the tube. If it doesn't improve, you may have to remove and replace that tube. Generally speaking, they will have one at the scene to do that, because the special duty nurses will change them at times too. This will be, you get called when the nurse isn't there. Generally though, they clear with suction. And remember, when you suction the child, you don't keep sucking. You allow them to breathe a little bit. Okay, don't suck out all the oxygen. Gastrostomy tube to provide nutrition or medications. Usually, sometimes they'll get pulled out. Sometimes they'll get plugged. You don't push them back in. Usually, it's just supportive care. Transport them and and we'll put them in. Central venous catheters, complications include infection, obstruction, dislodged or broken catheters. And those are transport cases. You transport the kid in, don't mess with the catheter. Ventricular shunts are put in for hydrocephalus, and so the shunt runs directly from usually the right or left ventricle, and there's a little reservoir pump in the back, and there's a point. Then the shunt goes into the abdomen, and the fluid drains into the peritoneum. Sometimes these things get plugged. Sometimes you get an infection. What you do, the child ends up becoming irritable, vomiting, maybe semi-comatose. Usually, if they have a pump, the mom or the caregiver has tried to pump it. It's not working. Patient needs to be transported, and ultimately we'll probably have to have a new shunt put in. And then, they will have, because you get enough pressure from the hydrocephalus, they may have cardiorespiratory issues while, as a side effect, and they're difficult to treat because, the respiratory one is okay, keep their oxygen up, and ventilate them as needed. Ventilate them to age rate. Generally speaking, though, most people will call you early enough that it's not going to be a major problem. Now, when you're dealing with a child with special needs, follow your regular assessment, but ask the parent questions to establish the baseline neurologic function and physiologic status and then try to talk or deal with the child at whatever developmental level they are. So if they are, a 12-year-old, but they're at the developmental level of a 6-year-old, so ask the parent, what's his speech, what's the normal speech, what is he, is he able to follow directions? There's no point in asking, and then it's always good to, if you can, to transport the child's primary caregiver with the child. Now, one of our biggest, and it's going to be a bigger issue because this last legislative thing, they passed a law called the Travis law, which we're supposed to have a way of identifying people with special needs at the scene of an injury or illness. Now, whether that becomes sticking a special sticker on the car and says, like when the car crashes, you can go out there and say, oh my God, there might be a kid with autism spectrum disorder in it, because these persons do not respond to emergencies and emergency personnel the same way that other people do. Specifically, and this Travis rule was designed for autism spectrum disorder. It's a neurologic disorder. It's probably genetic. Manifests as varying degrees of difficulty in communication, social understanding, and or cognitive development. All the way from the spectrum, from the kids who you have to put protective helmets on because they bang their heads on the crib all the time, or they just could rock back and forth, to extremely overly intelligent people who are described as the little professor. They have no social interaction, or very little social interaction, that the rest of us do. Disabilities and behavior vary across a huge spectrum. Characteristics could include not recognizing vehicle, badge, or uniform of a first responder and thinking that maybe you were there to arrest them, for example, or somehow take them into custody. To not understand what is expected of them. They don't respond to commands the same. They may run or move away when approached. They may not be able to talk, to communicate with words. They may only repeat back what is said, is sort of like Rain Man, you know, repeat things back. Communicate only with signs, languages, pictures, or gestures. Give misleading statements. Have problems speaking at a normal volume. Yell at you, or very quiet. If verbal, maybe honest to the point of bluntness. Not acknowledge physical pain. Or maybe hypersensitive. Not be able to communicate the extent of trauma due to lack of understanding or normal boundaries of relationships. The problem is when you don't have a caregiver there. And there's a couple of people, there's a couple folk in our community right now that we have seen multiple times that are in the autism spectrum disorder and are hard to, especially as they get big and bigger and stronger. Obtain history, if you can, from both the patient and the caregiver. Now, it's assuming that the patient's able to give you some history. Directly address the patient. Reorient the conversation to the patient. Establishes how the patient communicates, yes or no, either but just by asking directly or showing how he or she can do this. Keep questions short, direct, and simple. Avoid multi-step questions. Simpler the better. It's probably true for a lot of people, particularly in emergent situations. Now, look for repeated movement, swaying, tics, repeated phrases, things that would tip you off that maybe this is, you know. Now, don't be confused that all of your meth addicts are autism spectrum disorder, because they're probably not. Don't force eye contact. Most don't like to have direct eye contact. I know a couple of, I've known a couple of physicians in my life that I'm pretty sure were an autism spectrum disorder on the you know, very smart end, but they would not look at you. They won't look at you in the eye because they just don't like eye contact. Consider using pain scales or pain assessment techniques that include the caregiver. Step-by-step, explicit communication to the patient, what you're going to do next. If the caregiver will help you, show the steps of your examination. Don't just jump on the kid and start checking, say, you know, okay, you know, sometimes you have to say, okay, you can take the stethoscope, you can take this and put it right here on your arm. You can take a blood pressure that way. I'm going to raise the, you're going to feel a pressure on your arm. It won't hurt, but it's going to be a pressure. Don't tell them it's going to feel like a snake, because they don't like that. I've made that mistake before. Reward completion of tasks. Now, this may take a long time, so obviously, if this is an emergency, all bets are off. You just deal with what emergent problem you have. Now, you can say, gosh, Dr. Whitwer, I'm not sure I can go out now and take care of people under the new Travis rule because I haven't had enough training. Well, be assured there'll be more training coming down the pike because they wrote it into the law, and now we're mandated to come up with training. So, more news at 11. All right, I have to do a little ketamine thing here. This is a, okay, I arrived to find an adult female sitting up in a bed in an upstairs apartment, awake, alert, breathing very rapid in labor, appears to be in significant distress. She's on O2 nasal cannula, has a second cannula in her mouth to supplement O2. So this is a real case. Next to her are 3 rescue inhalers that she has used without success. The patient states, I can't breathe. The patient states she also has slight chest pain, which came after the shortness of breath. She's only able to speak in 1 to 2 word sentences, which makes communication difficult. Her family states she's been sick for several days. She's been hospitalized in the past for COPD and other breathing problems. One family member states the patient has been intubated several times. She has diminished wheezes, congestion to both lungs. I'm not sure what congestion means, but she is moved from small, crowded room to the living room couch where nebulized albuterol Atrovent are administered. A 4-lead, 12-lead, or 4-lead shows sinus tach at 134, ETCO2 is 62. Sounds like asthma / COPD / whatever. She is secured to the stair chair, moved to the cot, loaded in the ambulance. CPAP is administered without improvement. Solumedrol is administered. She continues to be very anxious and begins to say, intubate me, intubate me. Ketamine is administered IV and causes the patient to become very lethargic and sedated. Now, this was administered to sedate for the CPAP, not in preparation for intubation. She continues to breathe on the CPAP, and her SpO2 remains 96 to 98 throughout care. Moved to the cot in the ED and care transferred to Dr. Bell. Marty gets all of our stuff. She did not apparently have a sausage in her throat. However, the problem with this, she got 150 milligrams of ketamine IV. She also got mag sulfate. She didn't get an epi-drip, but that's okay because I'm not sure that this was purely just asthma. Probably COPD, but she got the intubating dose of ketamine. What's your sedative dose of ketamine? 0.3 per kilo, up to how much? 25. Okay. By the time she got to Marty, her O2 sat was still in the 92 range, but her CO2 was a little higher than that, it turned out. And she was only breathing about 8 times or less a minute, and so he just didn't intubate her. Didn't have to sedate her anymore. Use a little succinylcholine? Yeah. So the point is, too much sucks. I mean, too much ketamine. And once you've done the intubating dose, I mean, especially in a person like this, just go ahead and intubate her. You know, that would have done, I mean, she did okay. I mean, she did fine once she was intubated, she got better. But the thing is, that's just way too much ketamine for that. And I said, so how come you did that? He said, well, it's the first time I've given ketamine and I forgot. I miscalculated the dose. I said, only by a factor of 10. Well, that's not bad. So if it's the first time, look it up in your book. Use that peripheral brain. You don't have to, I don't expect you to remember everything up to the point of giving the drug. You know, it's the right drug, the right amount, to the right person. So here's your ketamine dosing, and we have changed this a little bit now to make things simple because we've had a couple of other cases involving ketamine for pain control that I want to make sure you're okay with. So, ketamine dosing, RS sedation, 2 milligrams per kilo, max 200. Pain control as an adjunct with fentanyl, 0.3 milligrams per kilo over 2 to 3 minutes, max of 25. Must have given at least 2 doses of fentanyl. I want you, because fentanyl will work. Now, in Oregon, they won't let you use ketamine for an adjunct until you've already given 200 milligrams to an adult. I think that's nonsense. But I want you to give at least a try. I mean, if I'm in pain, I'd like to have a little fentanyl myself. Now, pain control, if there's hemodynamic instability, in other words, shock. If they're in shock, I don't like them to get a lot of fentanyl. Drops your pressure. And Versed drops your pressure. If you're hemodynamically unstable already. So, also, 0.3 milligram per kilo over 2 to 3 minutes, the max of 25, but you can repeat it to control pain or to the point where the patient develops nystagmus, agitation, ventilatory compromise. So that allows you to use repeated doses, and you can also use a milligram per kilo IM. You can use this for painful procedures, painful extrication, but give it in repeating aliquots. It's exactly what the military is doing. It's the same exact thing.
What's the max if you do IM?
At a time?
Sure.
Generally 70 milligrams IM, and then repeat it after 30 minutes. Now, the pain control, you can repeat that a little, you know, if you haven't had reasonable pain control in, say, 5 to 10 minutes, give them another dose. If you're giving an IV.
Dr. Wilbur?
Yeah.
So with this change, you mentioned, like giving it, prior to like a painful procedure, extrication, so that's been
Right.
limited to, like tech rescues, situations where like a heavy rescue had to be there. So with this addition, is this now for the whole countywide? I have a patient in a vehicle with a femur fracture, they're gonna be really uncomfortable. If we remove them, we can give them the 1 milligram per kilogram IM dose prior to pulling them out.
Yeah,
So it's all medical.
if you couldn't start an IV, yeah.
Yeah, okay.
Yeah, yeah. And this is what the military is using in combat. You know, they give it IM when they can't get an IV going or when it's not practicable. So, and it works. Now, that's assuming that big, healthy, you know, military guys react to ketamine the same way as, you know, little COPDers do in this country. Yeah, but I mean, yeah, it's a good drug. If you want to have any backup on it, just call medical control if you're concerned about something. And I like it because whether it's IV or IM, I always like to give smaller amounts and repeat it, rather than get into the trouble where you've got, you know, if you know that 25 IV, unless you're going to intubate that person, 25 IV repeated, you'll never get into the point where you've got this person totally stoned because you've given so much. Some people get very agitated. You notice that the endpoint on the ketamine is agitation is one of the endpoints, because some people get really, they don't react as well to it. Okay, case reviews. If I can make this work. There we go. Okay. Well, on arrival, priority two for a seizure. On arrival, found a 3-year-old female lying supine on the couch at home. Patient had fixed gaze to the right, withdraws from pain. Mom states this is normal seizure activity for the patient. So you've already established this is a complex seizure. Patient began having a focal seizure 45 minutes before this. Mom says the usual seizure only lasts 20 minutes. Well, now this has been going on 45 minutes. Mother gave the patient 5 milligrams of Valium IM. Why her doc doesn't give her Versed is another question, because Valium is poorly absorbed IM. Patient continued to seize, so she called. Past history of cerebral palsy with epilepsy. Last seizure was 3 weeks prior. Patient withdraws from pain, has a fixed gaze to the right with occasional nystagmus. Lungs have bronchi throughout. Patient was given 1.6 milligrams of Versed IM without change. 24 gauge IV is established in right hand. EKG was sinus tach. An additional 1.6 milligrams of Versed given IV. Seizure appeared to be slowing. In other words, I'm not sure what that meant, because the only thing we were showing is she's got gaze, fixed gaze to the right, a little bit of nystagmus, no other seizure activity. It was probably a low-level seizure at that point. Put in a car seat, transported. She wanted to go to either Emmanuel or Portland, but they said, we're not sure that the seizure is over, we're not sure that she's stable, let's divert, and they stopped at medical center. Blood pressure's okay, pulse is up. Initial ET CO2 is 77, reduced to 56 en route. Still not quite good enough. Upon arrival to the patient has wandering eye movement, no other seizure activity. Eyes are just sort of moving back and forth. However, was noted by the ED doc, who used to be a paramedic, too much padding in the car seat, and the kid's chin was on its chest, tucked forward. And she's quite sedated. She's got a big tongue by definition, and she's really not ventilating well. So they maintained a correct position and then simple jaw thrust, which the RT held for quite a long time apparently, and they didn't have to intubate. And her CO2 came back, everything came back, and she was ultimately everything checked off, and she was not having any more seizure. She was sent to Portland via the Panda team. They came over and picked her up because status seizure, needs to be evaluated even though she's got a history of seizure disorder. No apparent infection.
You loaded her with one of the anticonvulsants, didn't
Yes, he loaded her, yeah,
Phosphate.
he loaded her with phospheniton, which is the active Dilantin becomes basically phospheniton. So we skip the middleman and give him phospheniton. More expensive, works better. But it's easy, it's quick for loading. Dilantin was a son of a gun to load people with. Dispatch for an unknown problem with man down. Well, this is not a man down at all. 15-year-old female prone on the sidewalk, CPR in progress. However, there's a police department or law enforcement is there, and an LED is there. So the child was 15-year-old playing a soccer field, asked the coach to go get a drink of water. School staff said the patient had no complaints prior to collapsing. No one witnessed the patient falling to the ground. Patient apparently had walked to the front of the building, collapsed on the sidewalk. They noted her then, and they activated 911 immediately. And the police, law enforcement person apparently was there, and CPR was being done. Patient had a single shock and was responding. Sinus tachycardia on the monitor to the medics. She was not waking up. Seemed to be stable. A non-rebreather. C-collar was she wasn't having appropriate ventilations in their feeling. She was secured, moved to the ambulance, transported. However, this one, I didn't even see until the second time through this, transport initiated and then slowed due to traffic from earlier bridge lift. Patient was RSI'd because no increasing LOC, airway was not being managed adequately, so she was given etomidate, suctional choline, intubated, positive waveform, and then some Versed, got another dose of Versed because she's still posturing, fighting against the straps. And then was given some fentanyl. Now, I'm thinking this over, I had, first, when I asked the medic when the medic was asked, why did you give fentanyl? I says, well, because I've watched and I've seen some of the ER physicians, and I guess OHSU has been teaching that intubation is painful, so you should treat them with pain meds, and I think that's nonsense. I've done as much of a review of the literature as I can find, and fentanyl is not included as post-intubation, except if you know there's some pain somewhere. My guess is she was having a little discomfort from being sparked and from being beat on her chest a few times, and maybe she had a minor laceration, and she did a face plant as well. And she's bucking the tube, and by bucking the tube, it probably causes her some discomfort. So I think the fentanyl, after we didn't get Versed to sedate her enough, the fentanyl certainly did help that. She stopped posturing and stopped fighting the tube. And I think that's appropriate, but not for the reason like we always, there are a couple of newer medics who apparently think that you should give fentanyl after intubation, and that's not true unless you have pain. I mean, the last thing she needs is more, in one sense, the last thing somebody who has a cardiac arrest needs is more drugs on board. So, this is a great case, though, because she's transported to Randall. She finally gets there, even though the bridge lift was okay. Now, this might have been a good... Yeah, you could, but then you don't, I hate to do I don't like to do long-term paralysis in somebody who's just survived a sudden arrest, because you kind of lose track of what's going on for a long time. It's not, it would have been an acceptable alternative. This seemed to work, and in thinking about it, obviously there's pain involved there someplace, and she seemed to do better with that. Now, patient was transported to Randall. She was there from the 27th of September through the 4th. Her discharge diagnosis was cardiac arrest with ventricular fibrillation, generalized convulsive epilepsy. She had a history of epilepsy, but she didn't have any seizures on this basis. Acute respiratory failure with hypoxia and hypercapnia, long QT syndrome. Now, turns out that one thing I learned this week is that there are now identified 87 different genes that can produce mostly QT syndrome and Brugada syndrome and things like that, but only 20 to 25% of people who have sudden cardiac arrest have anything that's congenital. And most of these things can't be treated anyway, except with an automatic internal cardiac defibrillator, which she has now, a nice AICD. So now she is the 4th kid in our area that has had cardiac arrest and ends up with a good resuscitation and ends up with a internal cardiac defibrillator. We've had 2 others that didn't do so well. So in 6 years, we've had 6 kids with sudden cardiac arrest at schools. Now, this was a great, clean save, early, very little downtime for her. She has full neurologic recovery. She has no issues at all, except so far she hasn't given, and we have pictures. We have a video of the whole thing because it's caught on the security camera. But so far we're having to negotiate to use those because she's a teenager and she doesn't, want the attention. Yeah.
So, in this case, if you said it wasn't sedating the patient, could you switch to
No.
What's the wise?
Well, if you'd use ketamine to, I don't think you'd use enough ketamine to sedate. You could try it, I suppose, at the low dose, 25 max 25.
So, for innovation, if 10 milligrams of percent isn't working to slow the patient, is it acceptable to switch to an innovation dose of ketamine?
No. Turn your face towards the microphone. No, I would not use an intubating dose of ketamine. You might try a sedating dose of ketamine.
So no problems using those back to back though?
Not particularly. I don't see any, at least at the low dose. I mean, you're just for sedation. I don't think that would be a real problem. There's no, to my knowledge, there's no increased, she did have a history of epilepsy, but there's no increase in epileptiform kind of things with ketamine. We used to worry that some of the sedative drugs lowered the seizure threshold, but I don't think that's true. So I would use a, you know, first of all, you could wait. I noticed the first dose was given, the first dose of Versed, the second dose was given 3 minutes after the first. I'm not sure that's enough time to see, because theoretically, you can only give, you're supposed to give the Versed at about 2 minutes anyway. So that's, I'm not sure that's enough time to say, yeah, we did or didn't stop the agitation. If you're worried about losing the tube, that's one thing. If the patient can be restrained, so like I say, when I was upset when I first saw the reason. I was also not happy with what the medic had told me. Was that, oh, you know, I like to use fentanyl because I've been told that intubation is painful. Intubation isn't painful, but there are things after the fact that or before the fact that could be causing the patient pain, and then and having a tube irritating your trachea is ultimately going to be uncomfortable. That's why they're bucking the tube there. So I think that was, in retrospect, that was a good choice. I had to think about it. Okay, priority 2 for a fall. This is interesting. Found a 12-year-old female lying left lateral on the ground at school, complains of numbness from the neck down. Past history, syncopal episode, or this history of this illness, quote, syncopal episode, complains of numbness and tingling before the syncopal episode, and then woke up on the ground. Quote, unable to move her body and denies any sensation. Denies history of similar episode, indicates she has an appointment to see a physician for heart palpitations and dizziness, so there's something going on. Denies other complaints. Exam is unremarkable, blood glucose was fine, skin pink, warm and dry, etc., etc. Clear, no findings on exam. Originally did not elicit any movement, or she would not move voluntarily. Complained of no sensation. And then, and during transport. Their differential diagnosis, they were a little suspicious, was syncope with deficits, rule out seizure versus conversion disorder, psychiatric, versus spinal cord injury. So they did what you're supposed to do. Full C-spine precautions, moved to the gurney, placed supine, transported. They didn't, because all the vitals and everything were okay, they didn't get excited, they didn't start IVs, didn't do all that sort of stuff. And so this is my comment on them. Had a really nice evaluation, and it was a good differential. And they did what they were supposed to do. The workup in the ED was entirely negative. She was ambulating totally normally at the time of discharge. She clearly, in retrospect, probably hyperventilated a bit and then had a syncopal episode, and hence her tingling and numbness. But then, so, and it turns out she probably has a little bit too much medication for ADD. I totally believe medication for ADD is the devil's work anyway, but this stuff is all basically just like amphetamines. And you get all the same weird things that happen with that. I don't think it's good for you. So she now is taking less of this, so we may not see this one again. Okay, difficulty breathing. Here's our 3-year-old white male sitting upright, mother in front yard, attended by fire. Patient's alert and significant respiratory distress. Per patient's mother, patient had a sudden onset of difficulty breathing while sitting watching TV. States the patient was seen yesterday as a PMD for an ongoing cold and was diagnosed with croup. Guess what he didn't get? A steroid. As stridorous wheeze, he has a large amount of mucus and rhinorrhea from his nose. Remember, it starts out as a cold. Mouth is visually inspected, no foreign object noted. Patient's breathing is shallow, rapid, and labored, with significant retractions noted. Cannot rule out airway obstruction or allergic reaction despite recent croup diagnosis. First dose of racemic epinephrine was not administered properly, as the medicine was not mixed with saline. Okay, well, that's true. That's really, so then he got a second and third dose. They're charted and they were given properly. Now, generally speaking, you don't have to give a second dose. Now, in this case, they did because it really wasn't nebulized. But the nice thing about this is, well, first of all, the patient's wheezes decreased markedly. They didn't need to get the third dose. And then transferred to the ER bed. Now, when we looked at the case after, he decided twice in the ED. So he had a really good case of really good croup. He decided in the ED when they stimulated him first with an IV and then with a blood draw attempt. He got dexamethasone IV. He didn't need any more racemic epinephrine. And he was admitted overnight for observation because he desatted 3 times altogether, because the first time you were there, and then see what his O2 was here. O2 sat was 89 on room air to start with. So he was below our magic number. So he's significant. But this also shows that kids are very tolerant of epinephrine and very tolerant. So, you know, he had 2 1/4 doses of racemic epinephrine without ever getting very excited. Let's see what his blood pressure, his pulse is 140. It's improving even with all that epinephrine. Okay, last case, I believe. Code 1 for trauma upgraded to code 3 by firearms. A 4-year-old. History. Patient was riding a scooter at skate park, hit from behind by another rider. Witness says he fell backward, hit the back of his head on pavement, not wearing a helmet, no LLC. However, he's got swelling starting around his right eye, not acting normal, now very lethargic, not able to answer questions. He's normally very talkative. There was a 4-hour delay in calling 911 because he initially had no complaints and he was with a different caregiver, and they contacted mother, and so it was 4 hours between the accident and the time. So he's alert to voice, but not talking, not answering questions, which is not his usual. He established that he's a very talkative kid. During transport, his eye swells more, right pupil becomes more dilated. Taken from mother's arm, placed on pediatric board, full C-spine, contacted PH Southwest, divert to a manual ED if patient is stable. Okay? Lethargic, makes eye contact, follows command, pulse slightly low, other vital signs, falls asleep quickly. Approximately 2 minutes from the hospital, patient suddenly vomited blood, rolled on the right side, cleared his own airway, maintained airway control, following commands, no significant changes to anything. He would fight. After each attempt to do IV access, and they arrived at a manual and let Randall do that. So, child had closed fracture of the skull, and facial bones. So he didn't land on his back of his head. Duh. No intracranial hemorrhage, no significant problem. He's just had a skull fracture and facial bones, and he was lethargic and not acting normally, because when kids swallow blood, it doesn't go down well, and it makes them sick, among other things. So he has a concussion and some facial fractures. Went home 2 days later.
Was he sober or was he intoxicated?
Well, I think the kid was probably sober. Now,
Never knows.
you never can tell. Okay. Any questions, any thoughts, any things? Yep.
Do you have any feedback on Pulsera?
This behavior.
Feedback, yeah, several. I mean, you're probably getting some from John.
I've gone with transport with AMR and arrived at ER with delivery transport, and they had no idea where something came in. So AMR submitted it, Pulsera, and no response when we got there.
Was it a trauma?
It was, no, it was medical.
What was it?
It was a medical cardio patient. He entered in on Pulsera and arrived and
Well, I haven't heard anything of that. Marty, you,
When did that happen?
that's probably a week ago.
Did they investigate that at the time?
I don't know, I don't know if I'm asking you guys.
Okay. Yeah, I didn't hear about it.
I haven't heard any, the only, and John is nodding his head, he hasn't heard about it either, so I don't know if he heard about it from his crew or not. We'll let Marty do what he can do in following up and seeing if there's a problem, but certainly if that went in on Pulsera, it should have gone right to the charge nurse.
If you could get me the run sheet, if I can get a copy of the run sheet, I can investigate it.
Yeah.
Yeah,
Well-
just give it to Mark, and I will,
Yeah, we should be able to find it fairly easily if it was a field cardioversion.
yep.
So, other than that, I've heard one of the feedbacks is that they still need on the, when you're bringing a stroke, the stroke people are generally quite happy with it, but you still have to put in last known well and the LAM score and things like that. So, okay.
That cardiac arrest,
As soon as we submit it to you, yeah.